everyone. iTech welcomes all the participants for today's National Distance Learning Seminar series. Today's topic is National HIV Counseling and Testing Services Guidelines Part 1, and speakers are Dr. Asha Hegde and Mr. Rajiv Sindhu. Dr. Asha Hegde is currently working as National Consultant Publicity with WHO at National AIDS Control Organization. She has been involved in planning and monitoring and implementing antiretroviral therapy for pregnant and breastfeeding women. Prior to this, Dr. Hegde has also served as Joint Director with Maharashtra State's AIDS Control Society. Mr. Rajiv Sindhu is currently working as Associate Consultant in NACO and has 10 years of experience in managing programs related to HIV/AIDS. He had worked towards the capacity building focus on NGO-led TI program. We welcome you both for today's NDLS session. Now, I would request Dr. Asha Hegde to kindly initiate the session.
Good afternoon, everybody. Thank you, Divya, for a warm welcome. At the outset, let me first thank iTech for allotting 2 sessions on National HIV Counseling and Testing Services Guidelines. As all of you are aware that Government of India has launched National HIV and Counseling Testing Guidelines by the Union Health Minister on World AIDS Day, December 2016. So what was the need for the new guidelines? All of us are aware that ICTC Operational Guidelines 2007 was being implemented in all the ICTCs so far. We are aware about the 90-90-90 global target. The first 90 refers to 90% of PLHIV who know their HIV status. Second 90 is 90% of PLHIV should be initiated on treatment, and the third 90 is 90% of the PLHIV should be virally suppressed. Now ICTC division caters to the first 90. So currently 2/3 of the PLHIV know their HIV status. So how do we bridge the remaining 1/3 gap? And that's why the new HIV Counseling and Testing Services Guidelines was drafted. So what is the difference between the new guidelines and the older 2007 guidelines? I'll be giving a brief summary on that. So today's session will be talking about what is the difference, and in the part 2 session we'll be talking about the documentation, that is reporting formats in the current guidelines. So basically the new guidelines first prioritizes who is the population who need to be tested in our facilities. So it speaks about 10 different population which we all aware about, but it specifically describes this population. Second thing it talks about pertaining to testing. The 2007 guidelines refers to only facility-based testing, and the new guidelines now speaks about going away from the facility, that we reach to the population through the community. So now this guidelines enables us to do HIV screening in the community. Now, under the program, when we refer to the community, there are 2 communities that we mainly refer to. One is a key population and second is a pregnant women. So the guideline describes about this. How do we address the key population in their community through our targeted intervention NGOs and also the other mechanism. The other big difference is about who does the testing. So the new guideline says that a trained ancillary healthcare provider may conduct HIV screening in the community. And a trained ancillary healthcare provider can be a counselor, ANM, outreach worker, even a peer of the TI can do HIV screening in the community. Now the next difference is, we all are aware about our medical colleges and district hospitals which are overloaded. And that's why we are saying about decentralization of HIV screening within the hospital, within the medical college. That means we may conduct HIV screening at the OPDs, at the casualty, even at the pre-operative ward. As we are aware that most of the individuals who come to the HIV testing center in a medical college are provider initiated, are referred by the provider, maybe for OPD, maybe from OPD, IPD, emergency or a pre-operative. So at all these places we may initiate screening centers over there, and these centers will report in a simple F-ICTC screening format, and the ICTC counselor will be responsible for the reporting of this F-ICTC. The new guidelines also says that no pregnant women should miss out HIV and syphilis testing. So ICTC, DSRC counselor, even the ART counselor, to ensure that every pregnant woman accesses services, who is accessing antenatal care services, should be tested for HIV and syphilis. The new guidelines also refers to EID, and it mentions that all standalone ICTC should be an EID center. All lab technicians need to be trained on EID collection, and a child may not travel. There is no need to travel for a distance of 150 km to go to a district hospital or a medical college. The new guidelines specifically talks about elimination of mother to child transmission and also about elimination of congenital syphilis. All of us are aware about known HIV positive case. So there is a population of known HIV positive women who becomes pregnant. So the ICTC as well as the ERT center where this pregnant woman is registered, where this women is registered for ERT services, may be on pre-ERT, may be on ERT, but has currently become pregnant now. This information also needs to be traveled back to the ICTC so that she can be recorded as known HIV positive pregnant woman in the section D. Also, the guideline addresses about the need of family testing, partner testing, and child testing. We should not forget, when a pregnant woman is coming to us who is HIV positive, we should also test her previous children. In the next session, on which refers to documentation, it speaks about registers, reports, and formats. You will see that the registers have been simplified. There's a specific card which is called as a discordant card or a follow-up card. Now this is there because we know that in a discordant couple, when the discordant partner comes for testing, generally a different PID number is given because it is very difficult for us to go back to the previous 6 months back testing details. And that's why we have framed a follow-up card or a discordant card wherein the PID number would be mentioned. So all ICTs is to ensure that the same PID is given during every follow-up. Also you will see in the registers, the first question is asked is whether you have been tested before, and if you have been tested before, do you have your earlier PID number? If you do not have your earlier PID number, then a new PID will be given, but it will be documented in the register as a patient who is coming for a second time testing and a new PID is being given. We have heard complaints from the ICTCs that we have a gender client line list, we have a pregnant woman line list which is very huge. So we have changed it into a PLHIV card and an ANC card which will be maintained in the standalone ICTC. Also, there is a lot of confusion about client initiated and provider initiated. How do we record it in the registers? So the word client initiated has been removed from the new guidelines. We'll be talking about self-initiated now. So the self-initiated should be recorded properly in the register. The first question that is asked again in the register is whether it's a client, whether it's a self-initiated or a provider initiated. And if provider initiated, then you have to give properly document the code of the provider initiated. And all the ICTC counselors will be happy to see that in the new guidelines, the SIMS ICTC format has been simplified from the 1200 cells which is there currently. Now we have decreased the number of data entry point to only 30% of what is there originally. Thank you so much. This was in brief about the changes in the current guidelines. I will now hand over the session to Mr. Rajiv Sindhu, who will take over the first part of today's session. Thank you.
Thank you very much, Dr. Asha. And as ma'am has talked about the new HCTS guideline, that is HIV Counseling and Testing Services guideline, that we have formally introduced in 1st December 2016. So now we are going towards whole presentations where we'll talk details about this new HCTS guidelines, what we have new in this and what will be the outcome of this guideline. Thank you very much. So the first way is now this release of WHO HCTS guideline, now HIV testing services guideline in 2015. So outline and content of new guidelines. This is National Consultations on HIV Testing Services Approach Writing Group formed. First meeting of writing group, meeting of TRG on ICTCs. So this is the process we have followed to to complete this HCTS guidelines. So and finally we have approval from the Health Minister of Government of India, and then we are just implementing in this new HCTS guidelines across the country. So we'll go for the next one according to this. So this first thing is the global UN 90-90-90 targets. So what is this 90-90 targets? Actually the UN and WHO have globally decided this 90-90-90 target. The first 90, as Dr. Asha have mentioned, the 90% of the people who are living with the HIV should know their own status. And the 90% of the peoples who knows that HIV status must be received the ART or must be linked to the ART centers. And the final one is the 90 of those who have linked to the ART should have suppressed viral load by 2020. This is the ultimate goal of our HIV and testing services. So this way we'll go for the next one, that will be what are the new abbreviation which we have using in this guideline, that is HCTS guideline 2016. One is that, as Dr. Asha mentioned, the community-based screening test. It's community-based screening test as we are reaching to the people. So now we are not waiting for the people should come or the client should come to the particular clinic, so health clinic or private clinics. Here we have introduced this guidelines and saying that all the patients where they are not reached or they are not able to come to the particular points, so we will be reaching over there. So this is called community. In detail, as we are proceeding in our presentations, we will be discussing in details. Now HCTS is what we are in since the session has started. We are discussing about the HIV counseling and testing services, and there are the 3 I's, that is intensified case finding, isonized preventive therapy, infection control. That all links to the HIV TB coordinations. You must be aware about the HIV TB coordinations. That is, the TB is the most prominent OI, opportunistic infections for HIV AIDS. And the PALS, most of the ICTC counselors and now the ART people must be knowing about this PALS. PALS is a software. We'll talk about this PALS. PALS is a software where we are recording the data of pregnant women and details. Individual tracking system is there, and this now onwards, after few days, we are implementing this not only for the pregnant women, also for the general clients. and then we'll talk about the 5 C's. This is a consent, confidentiality, counseling, correct test result, and connections. The consent is what we are take the consent of a client, of individual who are visiting to our standalone ICTCs. Now we have a little change in this taking the consents also. In this we have a new procedure to take the informed consent. There is a column which has been introduced in the counseling register that is maintained by the counselor, and we have a column that's meant for the consent, where the client will put his or her signature or the thumb impressions. So now we have removed our consent form from the standalone ICTC centers, or maybe the FICTC or PPP ICTC. So we have moved ahead towards the taking confirmed consent by taking the signature on the counseling register itself. The confidentiality, as all ICTC counselors are much aware about the confidentiality. So nothing to be elaborate about the confidentiality, as HIV, AIDS, you must be know about that stigma and discrimination. So confidentiality is to be maintained by all the counselor, that is all other facilities like FICTCs, PPP ICTCs, and now we have introduced this community-based screening ICTC, that means meant for the TIs also. And third is counseling. That's you are must be aware about. The counseling is the pre-test counseling, the post-test counseling, and follow-up counselings. And the correct test result, that is meant for the lab technician or of the standalone ICTCs, and other like FICTCs, where we whole blood finger prick test is being conducted. And the third about the connections here, we talk about the linkages to all other services like TB, like STIs, like ARTs, and other OPDs, where the opportunistic infections, we find that this is the opportunistic infections which has to be catered by that particular services. So we should connect that all the clients who are visiting to our standalone ICTC or FICTC or PPP ICTC, they should be connected to all other services which is required for them. So we'll proceed further. Now this is the major thing we have, major key changes we have introduced in this guideline 2016 is that HCTC facilities are divided into two categories. The first category is we call it's a screening facilities, and the second is called the confirmatory facilities. So first I will talk about the confirmatory facilities. All the stand-alone ICTCs centers will be functioning as the confirmatory facility, where all the three tests, antibody tests, are being conducted. They will be called like confirmatory facilities. And all other, now we are decentralizing our facilities, our services, to all other OPDs, IPDs, or any other, we can say emergency wards or whatever. I will say about in other slides also. So that all will be called as a screening facility, where only the first primary test will be conducted, and that will be the whole blood finger prick tests. So all the remaining facilities will be treated as, or will be considered as, the screening facilities. And the confirmatory facility, as you know about what are the confirmatory facilities. Now in this HCTS guidelines, we have 11 chapters, and we have a executive summary about those. And after that 11 chapter, we have annexes, as Dr. Asha have mentioned, that there will be a second sessions on this guideline regarding the register, form, reports, and cards. And this is all about, we have to share about this. So what is the session, what is the outcome of this sessions of those after completing these two sessions on this HCTS guideline part 1 and part 2 will ensure that all who have undergone this whole 2-day sessions, they will be considered as the master trainer, and they can train to other peoples who are or their peer counselor, or at the faculty basis they can treat to the like TI staffs and all others. So this we as we are progress will discuss about the key changes and others. So we'll go ahead for this. This is what we have discussed about. This is the first chapter. If we talk about the HCTS guidelines, the first chapter is the executive summary, and that will say that all HCTS, as we discussed, all HCTS facilities have been divided into two groups, that is FICTCs, that will be screening facilities that include FICTCs in PHCs, in sub-center and etc. Then we'll talk about the private sectors. If we have any PPTC, that will be also the screening facilities. And now this is the new term we are saying, that the TIICTC, TIFICTCs. So this is the TIFICTC. We'll discuss about the while we are discussing about the community-based screening tests. And this is the OPD, IPD, emergency wards, and then designated microscopic centers, then STI, RTI clinics, and pediatric OPD and ANC clinic, etc. And then what about the confirmatory facility? As we discussed about, is that the standalone ICTC will be called as the confirmatory facilities. And then again, the community-based HIV screening approach has been included in this. That is what we are emphasizing, the community-based screening or community-based testings. And now we have to involve the private sector in a greater amount, in a large volumes. So we have introduced, in this guideline we have introduced 3 different type of models to be to sign the MOU with the private sectors for sharing the data with us. So this is the new approach we for the PPP model, to increase the testing and improve the data sharing practices in the private sectors. Then in this we have in this guidelines we have standardized everything. Like we have standardized the role and responsibility of NACO, we have standardized the role and responsibility of SACS, and we have standardized the role and responsibility of DAPCO, we have standardized the role and responsibility of a standalone ICTC counselors, and then we can say the FICTCs and all other remainings. So we have standardized SOPs in this. So we'll go, while we are moving ahead, we'll talk about this standardized operating system. So now the next is to promote the early detection. That means all individuals should be screened for the TB and STI, as both the infections, the co-infections are very much prominent in HIV/AIDS patients, or HIV, the PLHIVs. Then the same way as we discussed earlier, the standard operating procedures for all counselors and lab technicians. So and this is also defined, that what is the role and responsibility as on the screening sites and for the confirmatory, and this is also unable to carry out this additional responsibility with ease. And this is the new sections we have introduced in this guideline, that is HIV, TB, collaborative activities, linkages, supply chain management, IEC activities, information management system. That is, if we say information management system, we are saying about the PALS and obviously the SIMS. And the importance of testing and syphilis for the pregnant women. The pregnant women are equally important for the HIV as well as for the syphilis, as Dr. Asha has described about this. So we will move ahead for this. See, the second chapter, the HIV, is most important and very much a new strategy which has been introduced in this chapter is the HIV counseling and testing services, where we'll talk about the HIV counseling services which will be provided into a screening facilities, a confirmatory facilities, and what is the process of that. And plus what the new approach is, we call is the community based screening testing. So while we are moving ahead, we'll be discussing about this. So first, as Dr. Asha has mentioned, that we have prioritized the populations in this. See, with the limitations of the human resource and the other resources, if we talk about the other resources in HIV/AIDS programs, if we want to achieve the first 90, we have to make the prioritized populations to reach first, and so that we can easily reach to the first 90. And if we reach to the first 90, then only we can talk about the second 90 or third 90. So in the prioritizing, we have different population that we have prioritized. As we go ahead, this is the infant and children first. The first priority populations what we have discussing about the infant and children's. They are very much part of this program. So we have to reach to these infant and children who are exposed to the HIV infections. So this is wait for a minute, as we are we have okay the priority population. And then the second one is the adolescent. Then adolescent, of course adolescent is also a priority for us, as they is the experimental age. They have the energy, they have the daring to do new things, and that makes their behavior in the risk manners, and that is more vulnerability towards the HIV problem. So, and the third one is the pregnant and breastfeeding women. Universal screening of pregnant women for HIV and syphilis is recommended. This is indirectly, or we can say directly also, to eliminate the new infection or HIV or syphilis among newborn babies. So STI and RTI attendees, we'll talk about the STI and RTI. All the attendees who are coming to the designated STI RTI centers should be screened for the HIV. And though this way we'll go for the occupational exposures. All healthcare, because all healthcare providers are also equally important for us, as they are also vulnerable to the HIV. So emergency settings, like the patient with the sign and symptom suggestive for HIV/AIDS, they are also vulnerable to the HIV. So we should make the priority for them also. The patient with the Kala Azara. Here we talk about in India, Kala Azara is reported to be the endemic in around 54 districts that across the Bihar. It will across Bihar, Jharkhand, Uttar Pradesh, and West Bengal. It is one of the opportunistic infections seen among the PLHIV, where the morbidity and mortality is high in HIV and Kala Azara co-infection patients. Hence, the National AIDS Control Program and the National Vector-Borne Disease Program have recommended that the HCTS should be offered to all the Kala Azara patients and the person is suspected to have the Kala Azara. So this is also important population for us. Then tuberculosis. As you know, the tuberculosis is also important, since the TB is the most common opportunistic infection and leading the cause of the mortality in people living with HIV, that means PLHIV. All the TB patients and the presumptive TB cases need to be tested for HIV. So this is also very important population for us. Then we'll talk about the sexual partner and spouse of PLHIV. As the ma'am also has discussed about the discordant couple, they are also very much important for us, and we say that the discordant couple should remain the discordant only. Then high risk group, HRG. Where HRG, if we talk about the HRG, that means we are talking about the core population, that is female sex worker, MSM, man having sex with the man, that includes your TZ, Hijras, all other community, and the injecting drug users. The third one is, and then we'll talk about the bridge population. Bridge population, we are talking about that the truckers and the migrants, they are also important. So this while we are discussing about the community based screening test, we will be discussing in detail about the FSW, MSM, and IDUs. Then the prison inmates, they are also important population for, and the person who have undergone sexual assault. The HCTC should be offered to all the individuals who have forced sexual assaults. So this is also important population for us. So as we'll proceed, we'll talk about. So this is the flow charts which HCTS facilities, the facility base and the community base, where you can make easily that what is the facility base and what is the community base. In community base, while we are discussing community, we'll be discussing in detail about this. So role and responsibility. Now this chapter also contains the role and responsibility and process flow of HCTS facilities, as I discussed earlier, and the community based HIV is just only repetitions we're talking. So this is the package of HIV testing services at the confirmatory facility. As you all aware that the all other facilities are at presently also you are delivering, like HIV testing, pre-test, post-test, EID, testing of sexual partners, screening of STI, all others outreach activities, all are you are doing right now also. What is the new in this now? When we are decentralizing this HCTS facilities and we are converting all other facility into the screening facilities, then you stand-alone ICTC counselor or stand-alone ICTC center will act as a nodal point for coordination, supportive supervision, capacity building, and supply chain management, that we about the cold chain management and etc. For all FICTC, that includes your PPP, that includes your TIICTC, that include your all other FICTCs. So this is the package of HIV test service as the screening facilities. We'll talk about the screening now. The pre-test, obviously the pre-test informed consent, as we had discussed earlier about this informed consent, that we have new procedure of taking the informed consent. Then HIV screening, screening for STI and RTI, TB and other co-infection, as we discussed earlier. This is also the post-test counseling and the linkage of stand-alone ICTC for confirmation of diagnosis and care and treatment, and linkage to other health services which is needed for that particular clients. So this is, now we'll talk about the major activity to execute role and responsibility of counselors. As you are being a counselor at a standalone ICTC, you must be knowing about all these things. So this counseling package is that same thing. The post-test counseling, obviously we'll start from the pre-test counseling, post-test counseling, follow-up counseling, and ensuring the audio-visual privacy and confidentiality. Same way the psychosocial support, family counselings, and outreach activities. And this IEC, obviously the in all the standalone ICTCs we have a designed IECs for specific thematic for the population, priority population, guiding individual for easy access to the facilities. Now the poster, flip books, and the PANIS model. I have to talk about the PANIS model. It is requested to all the standalone ICTC counselors, they should have the PANIS model and they should demonstrate wherever they feel the need of that demonstration, because the correct and consistent use of condom is very important for the HIV prevention program. The poster on standardized dashboard indicator should also be displayed. So as we are saying this, fine. Then priority population, as we discussed, we have to make the priority among the population, then referral and linkages, then supply chain logistic management and supportive supervision, as it is a usual process. Then maintenance of records and reports, including the data analysis. Yes, data analysis is very important, because if the field level people, if the field level counselor of a standalone ICTC, or if we go for further for the TIICTCs, they should analyze their data. What is the outcome of data which they are making for monthly or quarterly or 6 monthly or annually. They should maintain the record and register and prepare the monthly report, and that as the usual process they should upload their monthly reports by 5th of every month, and also prepare the quarterly SIMS reports. Then update details of HIV positive individuals on a weekly basis in PLHIV ART linkage system, that is we call SPALS. Prepare a monthly, quarterly, annual data analyze and display the updates. Facilities and monitor linkage and referral to and from the ICTC. That means the cross referral. We are talking about the cross referral. Now, as per these guidelines, we are not talking about only we are not talking about only the cross referrals. Here we are talking about not only the referrals, also we are talking about the linkages. And now the further, if we will go for the facility integrated counseling and testing centers. So this is FICTC. What are the service package is being given at the FICTC? It has been evolved a strategy with the RCH program for integrated HIV screening at all primary health centers and delivery points across India to increase an access of at-risk population of HCTS in a cost-effective manner. NACO is additions to establish standalone ICTC at CHC. It is a budgetary things. So if it is needed, and if we found that this can be implemented in a particular state or in sites. So we are in the process in 2017-18 budgets. It should be appropriately linked to the nearest standalone ICTCs. HIV screening at all FICTC will be implemented through their existing staff with the due sensitization, orientation, guidance, monitoring and supervision by the linked standalone ICTCs. Uh, so the facility will be used, now this is what is the mandatory for that screening facility. The facility will use whole blood finger prick test for HIV screening. So need based quantities of these kits to be supplied to the regular basis, so that no stock out should happen at all FICTC, and they should be properly linked with the standalone ICTCs. In case of unavailability of whole blood finger prick test kits, the facility should inform the linked standalone ICTC immediately, and they should either advise the individual to visit to the nearby standalone ICTCs or any other HCTS facilities. Then the facility, this is also that they have to maintain the temperature of 2 degree to 8 degrees Celsius of the kits, because it's mandatory for us. Then they have to maintain the logbook of the temperature, that we call the temperature tracking indicators, and to generated bio wastage should be, at proper, what are the different dustbins and the color of the dustbins and how they have been used in that, so that we can control the infections properly. So that guideline has to be followed. Then they ensure that each individual screen for HIV is given pre-test counseling and documented informed consent and performing HIV screening test and given post-test counseling. Then ensure audio-visual privacy and confidentiality. Of course, at presently also we are doing this. And if found reactive HIV screening linked to the individual, that particular linked standalone ICTCs under which that FICTC is working. Then if found non-reactive on HIV screen, the laboratory reports duly signed by the medical officer should be given to the individual during post-test counseling on the same day as the screening. So this is all about this facilitated facility integrated counseling and testing center. There are a few other things, the report of medical officer on stock situations, then SIMS by 5th of every month has to be done, uploaded, then testing individual at the OPD, IPD, emergency, casualty wards and general labs. So we have to decentralize this FICTC to OPD, IPD, emergency ward and casualty wards, and even for the general labs. So testing pregnant women, ANM, and ANM is also, along with the Asha, should identify all the pregnant women to hard to reach areas and ensure that they are undergo HIV screenings. And the infected paramedical staff for HIV and syphilis screening at the FICTC should coordinate with the concerned sub-center of ANM as well as the Asha and make a monthly plan. So this plan has to be like that. They have to pre-plan about the date, venue, estimated number of pregnant women. So this is one kind of community. For us, the community does not mean only the FSW, MSM or IDU or trucker or migrants. The pregnant woman is also community for us. So while we are designing for this testing of pregnant women, then also we have to make this date, venue, estimation, number of pregnant women to conduct the HIV and syphilis screening as a outreach activities. So this is the part of the community based screening test. Then HIV screening conduct a sub-center or during should be documented in the SIMS FICTC monthly report, the link PHCs, Public Health Services Order Centers. So now we have we'll talk about the PID numbers. As we are presently also we are giving the 23-digit unique code, that is we call the PID numbers, to every individual who's visiting to our standalone ICTCs and also for FICTCs. So this is the bifurcations of the 23 digits. The first two, as you know, the first 2 digits for the pregnant woman general guide, and the second 5 is report FICTC. That is it's for, I'm describing now right for the FICTC. FICTC means FICTC, that that's 5 digit, and the third 2 digits state code, then district codes, then ICTC center numbers, years, and individual series numbers. So this is the whole way we are going for 23 digits. So this is the standalone. What is the difference in standalones? We have this for standalone ICTC, we have second 6 digits for standalone ICTCs, standalone ICTC. So it makes 6 digits. So same way, but we have 23 digit unique codes, and that we call the PID in the counseling registers. So now this is the most important approach that we are talking about, this community based screening. Here what we mean by the community. Usually when we talk about the community means the female sex which are catered by TI programs, that is the FSW, MSMs, IDUs, migrant and trucker. But we have enlarged our universe in this community. The community means the community which is priority for us to get tested at their doorsteps or at the community level. So here we like pregnant women, like adolescents, they all are community for us. So while we are going for this, the community first, we have defined it the healthcare provider. As you know, the definition of healthcare provider being you are working in the health sectors, so no need to explain. Then this is the second is the ancillary healthcare provider. As you know, the counselor, we consider that the counselor, public health nurse, lady health provider, visitors, then ANMs, pharmacists, then multipurpose health workers, peer educator, outreach worker. Here if we talk about the TI setups. So this is the community based screening, where we'll discuss about this community based screening, that is the facility based services, community based service, and this is the mobile HCTS also. The mobile HCTS which are sponsored by or which are busted by the NHM, they are also be considered as the community based screening test services. Then if we are giving catering the ANM through this community based screen test, where the so we can say all ANC cases also can be considered under the community based screen test if we are going to the field and get testing over there. So that includes all, and we can, with the help of that like Asha workers and outreach workers, then only we are reaching this particular community of what we call the ANCs, antenatal care. And this is the then screening for HIV by target intervention. Obviously the target intervention is also the community for us, and an important community for us. So the community based screening test makes more convenient to the TI programs to reach their target and to reach that community which never comes to the government health sectors. Then the prison inmates at the workplace, and this is all we are talking about the community. So about the community based screening, we have made how we'll go about it. We have to ensure that all the TI should be trained on this community based screening test. They should be sensitive for this, and then the HIV screening facility should be selected before the plan day. This is the way of planning to this is called a micro plan. As we are go further, we'll say about this is micro plan. Micro plan means date, time, activities, referral sites, confirmatory testing, and proper linkages. Then the community mobilization. Prior to that, the peer educator and outreach worker, to ensure that the particular is the site where they are going for the community based screening test, they should visualize that particular sites, and they should make that the community mobilize happens, and on that particular day on which we are conducting that means the community based services, screening services, that the people should reach over that in that particular sites. Then logistic and transport. Obviously this is also very important for us, the logistic and transports, so that you can make out easily while we are going through that. The human resource and role and responsibilities. This is a role and responsibility. What is the role and responsibility of outreach worker? What is the role and responsibility of peer educator? What is the role and responsibility of a counselor or ANM of the TIs? Or what is the role and responsibility of a project? Overall, the whole activity will be under the project managers. So then biomedical waste management. Yeah. So the cold chain management, this is also important for us. The cold chain management, the monitoring and supervision and reporting, this is a final well. The monitoring, supervision and reporting is one of the important things. Then we'll talk about the chapter 3. Here we are talking about the counseling for HIV testing. Here we have informed, as we discuss about the informed is the same. The informed consent it will be included into the HIV counseling registers, where you have to take that thumb impression or the initial signature of that particular client who is going under the HIV testings. And there are the components which are made for the like non-ambulatory individuals or the individual before the age of 18, how they can go, and the consent for the coma. So all details are available in this. Then the pre-test counseling at ICTC, post-test counseling, this is all about, I'm talking about, this is the HIV counseling details. Earlier also, in earlier guideline in 2007, we do have all this. So we'll go for the new, what are the new we have done in that. So this is the follow-up counseling and HIV testing. Who all client, who all individuals should be called after 2 weeks, who all should be called after 3 months, who should be called after 6 months. So this is the chart we have prepared for that, and the follow-up counseling. So what is the time period of that particular client or particular individual for a follow-up, like discordant couples, or like the client who has been resulted as an indeterminate. So there are the different ways. So this is the couple counseling also introduced in this, as Dr. Asha has also mentioned about this couple counseling. Then sharing of sharing of HIV test results, and this is couple counseling make us more convenient to disclose the result of a particular individual in front of his spouse or partners. This is also the sharing confidentiality and medical disclosure, where are the mandatory for us, which make us, this is the process where we can follow. So this guidelines make us more. This is the SOP for HCTS screening facilities. You can go through and you can easily understand. This is the SOP for a counselor at HCTS confirmatory facilities. So, and these are the different registers where we can screening facilities, form in the triplicates. These are the annexure which we will be discussing in the next session. That means on the second. Then we'll go for the chapter 4, that is we call the HIV testing and quality management system. In HIV testing and quality management, we have the different algorithm, like algorithm at the blood bank, as we go algorithm at the blood bank, algorithm as the HIV sentinel and surveillance, algorithm at the if the patient is symptomatic, in that case what should be the algorithm. And this is the strategy 3. If you talk about the algorithm at your HIV testing confirmatory sites, that means standalone ICTCs. This is the EID algorithm. So this is all about the algorithm we are talk about. This is the way of process the quality assurance of HIV testing from Apex laboratory to the NRL to SRL and then standalone ICTCs. And same way from, well, we are managing the quality, the standalone ICTC to SRL to SRL to NRL and to NRL to the Apex laboratory. So the chapter 5th is the HIV TB collaborative activities. This is also very important. Well, we are talking about, this is the ICF. While we are talking about the HIV and TB, we should be more emphasized about the ICF, IPT and ICs. What is intensified case find? Then the intensified case finding is what? That we have to link all the symptomatic patient which are coming to the standalone ICTC to the RNTCP program. They should be linked to the RNTCP. And same way, if the patient is HIV positive, is PLHIV, in that case, irrespective of the duration of all four symptoms, they should be referred to the RNTCP programs. And same way, this IPT, isonized preventive therapy. Here we have introduced that all ART centers will be delivering this IPT medicines to the to the patient who are with the HIV positive, who are coming over registering to the ART center. Then infection control, as you know what is the infection control, that we have to take personal hygienes and public hygienes for that particular patient of HIV for TB. Sorry. Then mechanism at ICTC for end-to-end testing individual with the HIV and TB. This is all about, if we talk about the HIV TB. So chapter 6 is here the linkage of HIV testing for care, support and other preventions. This is what I am emphasizing from the session when we started this session, is the linkage of HIV testing to care and support and other supportive supervisions. So we have the linkage like and role and responsibility in linkage. What is the role and responsibility of standalone and then ART and then DAPCO? As you know, it's very easy. And this link, while we are talking about the link, it should be bidirectional. It can be a unidirectional, it can be a bidirectional. So from HCTS to TB or all other opportunistic infections, and same way from all other opportunistic infections or TB to the HCTS sites. So this is the two-way process. And the chapter 7th, if we talk about the capacity building, supportive supervision and functionary, as we know that this is to be there. We have different training level like induction training for standalone ICTC counselors, then the ART, and we have integrated that module, ART counselors and STI counselors. Same way we have different type of, like there are the training which are meant for the state level and there are the training which are meant for the district levels. And then supportive supervision at the various levels, the FICTC, standalone ICTC, district and states, and even the NACO. So this is supportive supervision level under the HCTS, the NACO, SACS, and then DAPCO to standalone and standalone to all other FICTCs. Then the supply chain management under HCTS. This is also important as we are maintaining the cold chain management system, that there should be a proper flow from the NACO to the field or to the facilities level, that there should be no stock out, there should be proper maintenance of the kits and everything. So this talks about this supply chain management. And then the chapter 9th is the advocacy and the communication and social mobilization. So the same advocacy, still we are doing advocacies and communications and IEC and social mobilization, where we talk about the social schemes. So in NACO website there is a portal, there is a link called the socialprotections.org.in, where you can go and you can access that which are the state which are providing different facilities or different schemes, social scheme for PL-HIV and even other marginalized group. So here the advocacy IC activities in this chapter. Then the 10th chapter is the information management system. As I talked about, there are two information management system we are talking about, that is called the PALS and then the SIMS. In PALS we are reporting for the, now at presently we are reporting for the pregnant women, but in future we are reporting for the general client also. So this is what the information management system, where the PALS and the SIMS, that is SIMS reporting that by 5th of every month that all the standalone ICTC counselor and even the FICTCs people should upload their data to this. And the last but not the least is the testing for the syphilis. Syphilis is also one of the important component for our HIV testing. So in this we say the importance of the testing for syphilis. Government of India is the signatory for global target for elimination of mother to child transmission of HIV and syphilis, and then screening of HIV syphilis has been included in essential package for the antenatal care services in the public as well as the private sector. All symptomatic and asymptomatic individuals seeking STI RTI services should be screened and treated for syphilis. This is, as we are talking, it's important. Then program recommended periodic screening of a high risk population for both HIV and syphilis. Screening for syphilis is responsible for all laboratories in healthcare system and management, and syphilis positive individual is the responsibility of medical officer at all health facilities institution in the country. So this is all about this new guidelines. We have discussed about this new guidelines. We have emphasized what are the new things and how that make us help to achieve our target of that first 90. So thank you very much, and then now we will take the there are a few queries or suggestions which are coming from different facilities. So this is the first Dr. B.B. Riwari as our prominent for ART. So thank you very much, sir, for being listening to these sessions. Now how many prisons have FICTCs or plan to establish the same? So FICTC, there are the few states, exactly I don't know the right now the numbers of how many FICTCs are there in the prison, but there are the states like in Chandigarh we do have, in UT Chandigarh State AIDS Control Society we have 3 FICTCs into the prisons, and the same way we do have in different, but exactly there is a plan to establish the same in different states. Then this is the HIV testing age limit for the adults. No, there is no age limit for the adult for HIV testing. Anyone who can walk into and can have the HIV. So yeah, below age is there, like if the person is below 18, so the consent of the guardian, the consent of parent has to be taken care for that. And please, this is the question, this is the query, that please explain the content is written or verbal. The consent is, will inform that this is the way we are taking the consent, but the information will be verbal and the signature or thumb impression is in like written. So indirectly we say that the person is informed that this is the test we are going to conduct. Okay, and if you say yes, we're going to conduct this test. We need to prepare a 10-point information sheet for the pre-test information for facilities which will not to do individual per testing counseling. Exactly, sir. It will be taken care for that. We'll prepare that information sheet for pre-test information for facilities. As we have discussed about the package, but yes, the 10-point information sheet for pre-test information for facility which will not be individual. Exactly, it will be taken care of. Then did we agree to pre-test counseling or pre-test informations? So you have asked to Dr. Asha, so she must be aware about this, and she will answer you this, please. So PALS is now available for check clients also as per the this linkage slide. Yes, we have introduced this PALS for the general client also. But it is now just implementing in few states only, that we have started into Rajasthan, and we have started into West Bengal, Meghalaya, and there are some part of the Bihar also. FICTC to standalone ICTC linkage need to be strengthened as we expand our FICTC in major way. Yes, sir. This will be exactly the well taken points, that the FICTC stand linkage need to be standard. As we why we are designing this PID numbers, we are also making the 2-digit for standalone ICTC, which is linked standalone ICTC, that particular FICTC. If that particular FICTC is linked to that particular standalone ICTC, then there will be the 2-digit of that particular standalone ICTC that will be used to make the PID. We are in the progress of that. Who will conducting HIV screening in the oh, sorry, I was not able to understand. Yes. And then is the consent essential for the IPD patient? Yes, the consent is essential for the IPD, but that can be taken from the person who is closely associated to the patients. We need to emphasize more on 3-test strategy, as many sites do not follow this. Exactly, we have to strengthen this strategy of 3 tests. It's well taken, sir. Then whether FICTC under quality controls? Yes, they will be under quality controls. That they all FICTC will be linked to the standalone ICTCs, and standalone ICTCs will be the whole responsible for quality controls, and even that will be taken care by the DAPCO and even by the SACs also. May HIV non-reactive patient refer to the RNTCP with 4S symptom from ICTCs? Non-reactive, yes, if they have the 4 symptoms, as we talk about the 4S of the symptoms, that is weight loss or cough of 2 weeks or night sweating or fever, we will be referring to that particular client or that particular patient to the RNTCP. This is yours. We have 18% loss in this linkage. We need to monitor this linkage loss more closely facility wise. Exactly, sir. We have 18 points clause in this, so it will be taken care. Sir, kindly explain the IS abbreviation. Okay, this is we talking about infection control. It's IC. It's not IS. I think so. Infection controls. If we talk about the infection controls, we are talking about that the personal hygiene of a patient, like putting the cuff and everything. So, and then, so please read the slide of SOP. Okay, SOP. Now it's not possible for me. In next session, it will be done for that. Can we expect such quality service from the CBS? Exactly. Many have the doubts for this community-based screening test, whether the quality will be maintained. This is what they again, the community-based screening test will be linked to the standalone ICTC, and the standalone ICTC's persons, that a nodal officer of that particular district and even the DAPCO peoples are wholly responsible for the quality of, and it will be taken care, because we have framed in a such a way that the quality will be taken care for that. Then HIV test should be done to all the patient who has attended pre-operative wards. Should be done to all patients, those who have, exactly, we can now that's what we are talking about, the decentralizations of the HIV screening, that we can go for the any patients who are into the emergency wards or any other place. Then adolescent age, like we have mentioned in the adolescent age is 10 to 19 years. So, but it is different for every programmatic point of view. Say, like, the psychology says something else, and then the social work says something else, and the sociology says something else. So adolescent, in this adolescent we have we call that the teenager who are between 10 to 18 years, 19 years. Then regarding couple counseling, his partner have right to know the result of partner. Exactly, we are introducing the couple counseling is just to that the result will be revealed in front of both the partners. I mean, like if the spouse is there, so we can reveal the result. We are doing the couple counseling and then we revealing the results. Whether need to be test spouse for all the pregnant women. Oh, so many questions. Whether need to be test spouse for all the pregnant women. Yes. We are emphasizing that all the if we are going for the pregnant women, the spouses should be get tested. But we are not. It's not like mandatory, but we need to test the spouse. And we, in this regards, in SIMS also we have introduced two new around 2 or 3 rows in which we can put this data of testing of spouse of the pregnant women. Thank you very much. And now the Central Prison, sir, which mentions website. Could you repeat it? Sorry, you can go through while you must be having this, so we can go through that and you can take that. May counsel use mask at the time of interaction with the TB? Obviously, they have to use. They should use as what the ethic or what the medical precaution says that they should use it. Thank you. We have tokens. Linked standalone, I say. Thank you very much for this. Now still is coming. Is the consent need at the directly deliveries? Is consent needed at direct? Yes, consent needed everywhere. And thank you very much so much for such a kindness. Thank you so much.
Thank you, Dr. Asha and Rajiv, for this informative session. Thanks to all the participants for patient listening. I request all the participants to kindly enter the e-poll which is going to display on the screen.